widely respected for his clinical expertise, surgical precision, and contribution to both academic as well as practical ophthalmology. Today, he will be sharing his insights on a topic that often poses significant challenges to even experienced surgeons, managing uveitic cataract. Tips and tricks. Over to you.
At the outset, I'd like to thank the entire organizing committee for giving me this opportunity, especially Dr. Lili. And I'd like to thank Dr. Gyan for two things. First of all, leaving uveitic cataract for me, and doing half of my job by talking on the small people management. So I'm going to discuss about some practical tips. I'm not going to detail theoretical things. So tips and tricks on cataract surgery in a uveitic patient. So this is the representative photo. So what actually, when we are doing cataract surgery in uveitic patient, what we are doing actually? So uveitis means it's already inflamed eye, and you are doing cataract surgery means you are imposing inflammation on that. So हामी नेपालीमा भन्छौँ नि आगोमा घिउ थप्ने. So that's the real meaning what we are doing in the cataract surgery in uveitic patient. So don't take this at a routine cataract surgery, because the careful timing, steps, and post-operative care is very much important, which I am going to give you some tips. Otherwise, you will land up with lots of these complications, toughening of the iris, the posterior capsular opacification, band keratopathy, retinal membrane, chronic cystoid macular edema, which ultimately compromises the vision. So uveitic cataract is the most common surgical indication in uveitis, account for 40% of the vision loss. Incidence is quite variable, and 1.2% of all cataract surgery, and definitely it is more common in chronic uveitis rather than acute uveitis. And the good news is almost 82% has a good visual acuity, especially in case of diffuse uveitis. So if you see the risk factor for developing cataract in uveitis, they are usually multifactorial. Uveitis itself causes the cataract, and steroid use, we have to use the steroid for a long time in the form of topical or periocular or systemic steroid. And the uveitis, which usually has a posterior synetia, hypopine, keratotic precipitates, and chronic duration are the more culprit to develop a cataract. So three major components to be addressed whenever you are dealing with the cataract. Uveitic cataract is pre, intra, and post, we all know. So when it comes with the pre-operative, you ask yourself 5 A's. So what is the age of the patient? What is the etiology of uveitis? What is the activity, whether the eye is quiet or not? What are the associated ocular pathologies and associated systemic illness? So coming to the age, so we have lots of discussion on the pediatric cataract. Definitely the pediatric cataract has still more challenges than adult cataract, because there is a high risk of post-operative inflammation, risk of myalgia, difficulty in IOR implantation, and managing the posterior synetia and other complications. Our second A is etiology, and the good news is that in diffuse uveitis, 92% of the patient gets 6 to 12 vision, and you can operate even in 4+ cells in uveitis, diffuse uveitis. So if you encounter a case of diffuse uveitis, you never need to make the eye quiet. You straight away go for clear cataract surgery, and it has very good outcome as well. The most important thing is you should be very ready to counsel the patient about the post-operative floaters. So what we usually counsel, it is just like a irritating nerve. It's not going to go in. But after the cataract surgery, the floaters that was not present previously now present. So patients should be ready for optical vitrectomy if needed in future. Whereas the other uveitis like SLP27, Behçet's uveitis, because they are more prone to because the tremendous post-operative inflammation. So good pre-operative control is very important. Third one is activity of uveitis. Timing is very much important. Always try to keep quiescence anterior chamber. Quiescence with 0 cells in AC at least for 3 months. Then you plan for cataract surgery, which most of the time is very much difficult where we are using in the Indo-Nepal border, because patients are very busy, they have not time. If you don't operate, they go to other center, they will operate. And you will end up with all these complications which we are facing nowadays. So even in my Behçet's patient, I will advise patient to the 6th month count biopsies of the eye before doing operation. And if fundus is visible, you should wait till the fundus is visible. You can see the when full inflammation is controlled. And there are certain scenarios where early cataract surgery is considered. Preoperative steroid, IMT, immunosuppression, there is no standard protocol, but usually what I follow is I start systemic steroid 3 days to 1 week before the starting surgery. Similarly, topical steroid, frequent topical steroid 2 days before surgery. And if patient is already on immunosuppression, I will step up the dose of immunosuppression before surgery. And we can consider the local steroid in the form of intravitreal ozurdex or triamcinolone or whatever thing. But always, if you are not sure about the etiology of uveitis, it is infective or not infective, always avoid topical, periocular steroid. And certain diseases like herpes and toxoplasma, they may miss the preoperative prophylaxis with the medication. And fourth one is the associated ocular pathology. There may be the macular pathology, optic disc pathology, and sometimes patient may have epiretinal membrane. In that condition, we have to go for cataract and vitrectomy. And cystal macular edema, you should go for intravitreal injection. And if fundus is not visible, we all know we should do a good B scan. And there are certain risk factors. You can just remember by the mnemonic SICS. These eyes are more developed to develop the post-operative hypertrophy, that is seclusion people with normal IOP, IOP less than 6, even with Quiescence eye, cyclitic membrane in UVM, and severe or poorly controlled inflammation. So pre-operative counseling is very much important regarding the altered visual prognosis, longer surgical recovery time, delayed and suboptimal visual recovery, long-term need of medications, may use extra cost, we have to use the all expansion devices and all these things. Coming to the intraoperative challenges, Dr. Bain has clearly mentioned. So the type of anesthesia may be multifactorial. Usually we don't recommend topical anesthesia, better to go for peribulbar or posterior subcutaneous block. And incision, corneal, if there is corneal band, go for clear scleral tunnel. If there is scleral band, you can go for clear corneal incision and try to make a little bit longer tunnel. And regarding the choice of surgery, there is always debate, but it is considered that economical is relatively better, but one study has shown that there is not much difference in incidence of PCO, macular edema, ERM, and all these things. And if you have a cataract and glaucoma in uveitic patient, we usually don't recommend doing the combined surgery, do the cataract surgery first, and we go for glaucoma surgery later on. Whereas it is associated with retinal surgery, you can go for combined surgery. Small pupil management strategy, I'm not going to talk that much. So there are two types of strategy. One is without using pupillary expansion devices, and another is pupillary expansion devices. But there are certain modifications. You can use the viscoadaptive OVDs if you have access to them. You decrease the fluidics parameter, use chopping techniques, bimanual, these are some safe techniques. And no pupil expansion devices, multiple lensotomy, which is usually nowadays not that much popular. So you can try all these things. And definitely the expansion devices are the iris rods, iris rings, VX expander, and there are other devices as well. And step modification, definitely you will use triton group for visualization. In viscoelastic, you can use both the viscoelastic if you have access. In phaco technique, we usually recommend low energy, slow motion phaco to minimize the inflammation. And capsular policing is very much important. Always try to go behind the IOL and try to remove the viscoelastic, because otherwise it will create a more post-operative inflammation. And regarding the types of IOL, there are different opinions, but the conclusion is that the IOL is acrylic IOL is better. Hydrophobic is preferred over the hydrophilic. Though there is no much difference rate in the PCO formation. Always avoid the AC IOL, avoid premium IOLs in these patients. A lower cost of in complication than silicone in unmodified, and IOL placement definitely intact placement is more recommended. And post-operative complication, it is told that the basic principle is always over-treat and relax rather than under-treat and chasing the patient. So aggressive topical steroid, intravitreal steroid, NSAID, posterior synetia, and keep this people mobile. And there are issue of PCO and capsular phimosis you can address by the certain modification in the technique. And post-op CME, the incidence of post-op CME in uveitic eye with well-controlled inflammation is almost comparable to the non-uveitic eye. Risk of cystoid macular edema is almost 6 to 7 times higher in previously inflamed eye, and usually the main period of developing is 7 months, which is considered. So the take-home message, simply ABCDE mnemonic you can remember. So assess and address the underlying uveitis, treat uveitis with steroid, plus minus immunosuppression. So best timing for surgery planning is important, at least 3 to 6 months of quiescence. Quiescence with 0 cells in the as much as possible. Choose the right surgical approach, phaco or MSICS, and you should use the expansion devices and dialogue with the patient properly. That is, the counseling is very much important regarding the long-term use of need of medication, suboptimal delay recovery, all these things is matter. and evaluate and prepare the post-operative complication. So the uveitic cataract, whenever you are dealing, be prepared for a long journey. It's not like a 6-week or 3-month journey with lots of ups and downs and surprises. So this one beautiful article published in 2020 in Saudi Journal. You can go through this article if you will. So I always tell my fellow and resident that I may not be able to teach you uveitis, but I can teach you how to think in uveitis. So that's the very much important. Thank you very much for your kind attention.